Hi, Ojo, and I'm standing in for Professor Bankole, who is unavoidably absent. I am sure we're going to have another wonderful time today as we talk about endovascular treatment of retinoblastoma. Um, it's actually 2 p.m. in Nigeria. I understand the time difference may make it slightly challenging for others. So it's probably morning, of course, it's morning in US and other places. Um, we have 11 participants. I think we should start, except you want us to wait for another 2 or 3 minutes.
Um,
Dr. Okafor, what do you think?
you asking me or someone else?
Or yeah,
Oh,
Martinez, thank you so much. Yes,
hi.
to tie up, do you mind if we just give like 2 minutes or so we can remind all our colleagues on
Other platforms.
the NANS platform, if you don't mind just sending them a reminder, sir, that we're
Okay,
starting
so you
and our
have
speaker
minutes,
is here.
but I will send the reminders right
Thank
now.
you. That'll be kind.
All right.
Dr. Martinez, is that okay with you? Just 2, 3 minutes?
Yeah,
Thank you so
absolutely.
much.
The more the merrier, of course, right?
And we do have much more than this coming on board.
Yeah.
Just
Okay.
like a quick nudge.
Sounds good. Hi, Shivani. I invited Shivani.
I'm so happy to be here. Thank you.
Oh, thank you for coming.
You muted?
Dr. Joe, maybe we should just go ahead while we wait for others to keep joining the platform.
Okay, yes, I agree so too. It's 5 minutes past the time, and right now we have over 20 people. I am sure more will join. I've been able to send the notice to all the platforms that we previously advertised the program. So I think we should go ahead. Welcome once again, everyone, and we'll welcome others later to this monthly neurosurgery or endovascular grand round. It's been a while we've been having this, and each time we have learned something new. So today we'll be talking about endovascular treatment of retinoblastoma, and we have Dr. Mesha Martinez, who will give the talk. Very soon, Dr. Kaffor will give the proper introduction. But just a few housekeeping rule. Please, if you are not talking, can you kindly mute your microphone? That way, we will reduce distraction and we can benefit maximally from the presentation. Once again, Professor Bankole is unavoidably absent, and I'll be standing in for him. We all know Dr. Okafor, who has been part of the team ever since we started, and actually one of the brain behind this grand round with Dr. Bankole. Dr. Okafor, you're welcome, and Dr. Mesha Martinez, you're welcome. Kindly introduce the speaker, Dr. Okafor.
Thank you, Dr. Tayo Joe. Thank you so much. I have the distinct pleasure to welcome our guest speaker for this bi-monthly endovascular neurosurgery grand rounds with the Lagos University Teaching Hospital. Today we have Dr. Mesha Martinez. She is an assistant professor of radiology at the Indiana University School of Medicine in Indiana. She's also the director of pediatric neurointerventional radiology at Riley Hospital for Children and the founder of the Pediatric Neurointerventional Program. Dr. Martinez completed her Doctor of Medicine from the Temple University Hospital in Philadelphia, Pennsylvania, with subsequent training in internal medicine and completed a diagnostic radiology residency. She did additional training in pediatric neuroradiology at Lucille Packard Children's Hospital in Stanford and pediatric radiology at the Children's Hospital of Philadelphia, at St. Christopher's Hospital for Children in Philadelphia as well. She completed an ACGME accredited fellowship in pediatric radiology at the Children's Hospital of Philadelphia and diagnostic neuroradiology at the Icahn School of Medicine, Mount Sinai Hospital in New York City, and endovascular surgical neuroradiology at Johns Hopkins Hospital in Baltimore. Dr. Martinez is a strong advocate for health equity and diversity and a minority leadership in medicine, and current chair of the Black Neurointerventionalists and their allies affinity group of the SNIS. In addition, she's a huge patient champion and a doting wife and mother. That is a combination that is beautiful. So with that, we want to welcome Dr. Martinez to give us this presentation on endovascular treatments of retinoblastoma. You're welcome. Thank you.
Thank you so much for that wonderful introduction. I am truly excited to be here. Having a little bit of issues with my slides, so give me 1 second. Okay, so I don't need to introduce myself too much more. Thank you for that again for the invitation and the introduction. I'm Mesha Martinez, and today I'm going to be talking about endovascular treatment of retinoblastoma. The purpose of this lecture is truly a how-to. It's not so much about the data because the data is mixed and there's a lot of retrospective case series that have been presented in the literature. But it really is for the clinician who's saying, we have children who suffer from retinoblastoma, and we would like to offer this treatment for them, which is becoming the standard of care in the United States. And we're hoping that this can trickle to other countries around the world as more evidence is revealed. So my disclosures are, I am a consultant for Viz.ai. Also, I will be using brand names of products, but for educational purposes only. I have no financial relationships to the products that are mentioned. And lastly, I am truly a pediatric physician and enthusiast, and I like to put pictures like this into my presentation because it's just adorable. And usually I say children are not little adults as I preface all my talks to remind everyone it's going to be a little bit different what I'm talking about. So I love to learn through cases. And so what I'm going to do is take you through 5 cases. And those 5 cases are going to take you from the time the patient is introduced to you during your first consultation, whether they're recommended to you by a pediatrician, ophthalmologist, hematologist, oncologist. So we'll start off with case number 1. Case number 2 is going to be what you're actually doing in the endovascular suite. Case number 3 is going to be touching on post-op management and complications. Case number 4, we're going to touch on challenges associated with IAC. And number 5, controversy associated with IAC. Now, there's a lot of controversy, and I only have an hour. And when I started putting this talk together, I started saying, oh my goodness, I'm going to run out of time. But we will touch on the major controversies and what the recommendations are thus far. Then we'll conclude the talk. But with a brief introduction, retinoblastoma, as our audience is probably knows, is the most common intraocular cancer in the world. The highest volumes are going to be in Africa and India. The goals of treatment are very important, and I really want us to look at this line, look at this slide, and if we're not walking with much away from this lecture, I want you to remember this. The goals of treatment when a child is presenting with retinoblastoma is 1, to preserve their life. At the end of the day, if a child does not have their eye, they can still live. But if an eye containing retinoblastoma, and blastoma we know is a very cancerous disease, very aggressive disease, if the eye remains in with the retinoblastoma, the natural history will be death. And that's going to be due to metastasis and growth of that retinoblastoma outside of the globe or the orbit. Our second goal when we're treating this disease is to preserve the globe. So first goal, again, we want to save baby's life. We don't want metastases, but if we can also save baby's life and keep the orbit inside the socket, that's our goal as well. Last is to save vision. We would like to save vision if the tumor is not sitting on the macula. We would like to save vision at all costs, but that's probably the least of our priorities when we're looking at treating these patients. The standard of care thus far is enucleation, and this remains the standard of the care all over the world. At the end of the day, with the goal of saving baby's life, enucleation treats this disease. However, patients who suffer from bilateral retinoblastoma, pretty severe disease, likely due to an RB1 mutation, then enucleation of both eyes seems to be something that we have a hard time, and parents definitely have a hard time wrapping their heads around. But remember, if we want to preserve life, by all means necessary, that's our goal. So enucleation remains an option of care. In 2004, the Japanese came up with a way to endovascularly treat retinoblastoma. They would place a balloon in the supraclinoid segment of the ICA above the ophthalmic artery, and then they would use an additional catheter to infuse chemotherapy below the balloon with the hopes that the direction would take it into the IAC. In 2006, Aberson and Govin in New York City came up with the microcatheter technique, and that is going to be the technique that I discussed today. We can expect that our children who are undergoing this procedure will receive 1 to 3 chemotherapy agents. I'll take you a little bit through our journey as a new center when I started our program at Riley. On average, children will have about 3 sessions, 3 to 4, depending on what paper you read, but 3 seems to be the magic number. And normally these sessions are repeated every 4 weeks. And then when we look at the stats, which they're all over the place because there's a lot of different, like I said, retrospective studies, case series where people are kind of having their own protocols, having their own methods. Eye salvage, meaning we don't have to enucleate the eye, is going to be 70 to 100%. And of course, this depends on the grade of disease, the methods, et cetera, et cetera. There's a lot of variation in treatment at this point. So as we said, we're going to start off with case number 1. This is going to be, we're going to be talking about preoperative evaluation. You're getting the referral. And this was a case of a 5-week-old girl who's presenting with bilateral retinoblastoma. The mother has a history of a mutation of the RB1 gene. And so oftentimes, if a patient is presenting with bilateral disease at a very young age, less than 1 year old, you can suspect that there's going to be a RB1 gene mutation. And it's not uncommon that the parents have suffered from this disease themselves and passed it on to their children. Now, in this scenario, this little cute little baby, who I will never forget, her mom was blind in both eyes. She had lost both of her eyes due to retinoblastoma. One had to be enucleated, one was still in, but non-functional. And so mom, this was her 3rd child. All of the previous children did not have the RB1 mutation passed on to them, but this baby did. And so here we can see the MRI. And for those of you who are not radiologists, tell me which eye looks abnormal. But then you may be wondering, why did you say the baby has bilateral disease? Well, we must remember that sometimes when we have grade A disease, which means a spot or a focus of tumor, we may not pick it up on our MRI. Our spatial resolution on MRI, sometimes it really struggles with things that are less than 3 millimeters. And so for this child, the disease was actually identified by the ophthalmologist and couldn't be picked up on MRI. But here we can see we have retinoblastoma in the left, in the right eye that we can see very clearly. All right, so most of the time, you're going to get this referral from ophthalmology. The child presents to the pediatrician due to parents' concerns. Pediatrician may perform an otoscope exam, may not, usually sends them on to an eye specialist. Eye specialist then goes on to perform what we call an exam under anesthesia, EUA. Now, for the longest time, I thought, what was this special term? But it just means they're going to dilate the eye and put the child to sleep and look at the eye, because no child who's 5 weeks or 1 year old is really going to let someone be up in their eye for a very long time. So basically, they're just putting the child to sleep. They're looking into each eye. They're catching if there's bilateral involvement, because sometimes patients can present with changes in one eye, but the other eye parents didn't note because the tumor is too small. And then they're going to say, hey, if we can get endovascular treatment, let's try to do so. Now, what are you doing as the neurointerventionist? What is your vetting criteria? Now, the ophthalmologist may or may not reach out to you, meaning a lot of times decisions are made on if the patient's going to receive chemotherapy without you, if the patient is going to undergo enucleation performed by the ophthalmologist without you, but there's going to be certain times they're going to refer them to you. So what is your vetting criteria? Well, you're not a trained ophthalmologist, so I wanted to break it down for the things that we should be looking for. And number one is going to be access, right? This is, at the end of the day, if you're not a pediatric neurointerventionalist, which I consider myself because a lot of my practice, 75% of it, I'm dealing with tiny vessels and doing tiny things with tiny people. But if you're an adult specialist and you're starting this practice, or you have a child that comes to your institution and you want to start this, the first thing you want to assess the child for is access. So how many kilograms is this child weighing is the first thing you want to ask your ophthalmologist. And so let's talk about that a bit more. Now, if you're a pediatric neurointerventionalist and you're dealing with tiny vessels all the time and you're doing Van Galen malformations, et cetera, then I would say there's no age limitation or size limitation to you outside of your device parameters. But those who are just getting started, who want good outcomes, who want to do good instead of harm, my recommendation to you, if you're just starting out, the goal is to treat kids who are 3 months and above. And what are we doing for the kids who are less than 3 months, like this little baby who's 5 weeks? The recommendation when IAC first started was to bridge with systemic chemotherapy. So let baby get sizable enough, let common femoral artery get sizable enough until baby gets about 3 months and about 6 kilograms. And then you're getting access. You should be successful and not cause harm. Things that I recommend for those just starting out, and actually for all neurointerventionists who continue this work, is getting access with a 4 French sheath, maybe a 3 French sheath. I don't really recommend it, and I'll talk about that more. And having a guide. A 4 French ankle taper glide is what I use for my guide. And again, I'll get into that a bit more, but I wholeheartedly support that that protocol, even though a lot of the experience centers with higher volumes, I admit, suggest doing a 3 French shift with a microcatheter, but we'll talk about why I don't necessarily recommend that. So there are some contraindications. If the baby has metastatic disease and you are reviewing these scans, you don't want to do IAC. They definitely need systemic chemotherapy, enucleation, etc. If the ophthalmologist has the inability to view the entire eye, which sometimes happens due to cataract formation or just disease, you're not going to know if there's residual tumor with your intraarterial chemotherapy treatments. And so you don't want to end up doing something and the patient's going to get their eye enucleated anyway. And cataract formation is one of the complications that we see that children develop because of retinoblastoma disease in itself, not the idea that it comes from our fluoroscopy exams, but the disease actually causes cataract formation to form quickly, and then that keeps the window closed for the ophthalmologist to be able to see into the eye. All right, so access, you want to know the size of baby, you want to know all the things we just talked about, but then also kid is going to undergo MRI, usually of the brain, in order to make sure they don't have metastatic disease or have what we call is pineoblastoma associated with their retinoblastoma. And so with that protocol, when we started our program, we added in an MRA without contrast. But then we realized that things can get tricky when you're trying to see where the ophthalmic artery is arising from if you do an MRI time of flight and not an MRA with contrast as well. Now, this question mark linked to GA, can you do all this imaging when your ophthalmologist does his exam under general anesthesia? So the patient gets their examination under general anesthesia, and then they go to the MRI scanner to have the subsequent MRI orbits, MRI brain, MRA. It's a good idea to try to link anesthesia so the child doesn't have to undergo multiple general anesthesia sessions. Just something to keep in the back of your mind. So we're talking about the MRI, and I just wanted to stop here before I go into MRA talk. But here we can see for the MRI, you want to make sure there's no tumor extension. These are considered high clinical risk features. So here on my left, we can see that there is tumor filling the globe, okay? And then when we look really, really closely, we can see that there's tumor in the right eye as well. But there is a high clinical feature on here. We can see that the sclera seems to be discontinuous, and there is some tumor that's extended to the retroorbital fat. And so that is something that is a high risk feature and may indicate that there is a increased frequency of metastatic disease. A lot of ophthalmologists will say we're going to go with systemic chemotherapy, but some ophthalmologists may say let's do IAC, and we'll talk about that. Case number 5 or 4, one of those. Here we can see this is actually from AJNR, because I haven't had a patient in my clinical cohort of 30 that had optic nerve extension shown on MRI. We have had patients who didn't demonstrate these type of findings where you have thickening of the optic nerve, you're not seeing the CSF surrounding the optic nerve in a nerve sheath. But those patients we found out they had optic nerve extension after they underwent enucleation. So again, MRI is not the end all be all. It only can see certain things, and the spatial resolution is suboptimal in comparison to X-ray. Now here, we're going to talk more about the MRA. So remember I said, patient's going to get an orbit and they're going to get a MRI brain to make sure they don't have metastatic disease. But also what you want to encourage your clinicians to get is a pre-op MRA. And the reason being is that you want to be well prepared for when you go into the angio suite to know where the ophthalmic artery is. And so here was a scenario of a little guy who had the MRA, and this is probably like 1 frame per second, so it's super slow. So I'm going to slide through it. And we were looking, you can see the tumor is in the right eye and in the left eye. Okay, we can kind of see this soft tissue. And when you look at the supraclinoid area, it looks like both of the ophthalmic arteries are arising from the ICA. Okay, and so when we stop scrolling, let's see, we can see, looks like there's some ophthalmic artery here, and this really looks like there's ophthalmic artery here. But what we learned is that this was actually due to a collateral. And you can kind of, maybe when I tell you this retrospectively now, think, oh yeah, you can actually kind of see this connecting, but here it's very faint, small, and is there a true connection? Don't go through that. Just start doing your MRIs with contrast afterwards so you can see if there's a pacification of the ophthalmic artery. And so here is a right internal carotid artery injection. And as you can see, my guide is here. And when we go up to the ophthalmic segment of the ICA, we don't see anything, okay? And that was because this little guy had it arising from the sphenopalatine branch of his external carotid artery. And so here I draw you a line. Here you can see my catheter in the external carotid artery. I draw a pathway through the internal maxillary artery, sphenopalatine branch is coming off, and then we can actually see we have this collateral branch that leads back to the partially opacified ICA, which this was accident, right? Like there was reflux into the ICA, but it actually shows you quite nicely this collateral from the less common sphenopalatine artery. So you kind of want to know these things before you go into the procedure, because then you're prepared to get right catheter in the ECA. You're not futzing around in the ICA. You're decreasing risk of stroke by not having to go into the the ICA, et cetera, et cetera. And then the key for this case truly was the Aristotle wire. Now, I know not everyone has access to this wire, but I hugely encourage you to advocate to get this wire, not because I get a cut for promoting this wire, but because this wire is the truth and it will get you where you need to go. Like this catheter, this wire will go anywhere. All the catheters haven't been able to follow it. It's amazing. All right, so you're getting, access, baby size, you're feeling comfortable, you got a good common femoral artery because they're 3 months old. You have this MRA with and without contrast, the ophthalmic artery is there, you're excited. And now you want to talk about dose, okay? Now, most of the time, your hematology oncologist and your ophthalmologist are going to dictate to you what dosing they want. And back when I started this program, we sat down as a multidisciplinary team, went through the literature, came up with this chart that was published in the literature. This is a controversial point. And the reason being is that we had some children who ended up going for second opinions at other institutions, and we found out that their treatment regimens differed from ours. So here you can see we're here, Indianapolis, and we're similar to other programs in Phoenix and let's see, Phoenix and Boston, maybe. Well, no, not quite. But you can see there's a range here. Philadelphia, they give 5 milligrams of methylon no matter what, no matter the size. And here back on our chart, we didn't want to exceed 0.4 milligrams per kilogram. We never have had systemic toxicity, meaning a drop in the white count. But others institutions are doing different things. And so that has led us to reassess what we're doing. We've actually been working with our hematologists, oncologists, because they're more aware of what topotecan, carboplatin does on a systemic level. So they're giving us the ranges, and we're dialing up and being a bit more aggressive, knowing that our systemic complications are going to increase, but not wanting to have to move towards enucleation. So this is a controversial topic. Many centers are doing many different things. that is something we should all be working on as a community, as a world, and as a whole, is to get more standardization, more random clinical controlled trials to get this to be a standard. All right, so I cannot stress enough the importance of having a multidisciplinary team. When it comes to pediatric neuro-IR, you cannot do this alone. You definitely want your pediatric counterparts to be well involved. You truly are stronger together. And so as we sat down, we came up with our protocols, we made these decisions together. We started our program, and then every month we have a tumor retinoblastoma tumor board where we discuss all the kids, whether they're undergoing systemic chemotherapy, whether they underwent enucleation. We'll have the pathologist come and visit and share with us their findings after enucleation. And there's just so much learning. And I feel like, given the fact that there's not a lot of perspective data to drive our decisions, this is a need and a must for those who are starting a new program. All right, then after you have your multidisciplinary meeting, and oftentimes we have a multidisciplinary clinic visit where I'm there, I do the neuroendovascular part, hematology oncology is there, they do the chemotherapy part, ophthalmology, usually we meet the parents after the exam under anesthesia, so they kind of introduce us to the parents, drop neuro-IR off, and hematology oncology off. We talk to the parents right on the same day so they don't have to keep coming into the hospital over and over. Yes, this requires me to drop what I'm doing. Yes, this may delay my next case I'm starting, but it's very important to make those parents who just found out their children were diagnosed with cancer feel like they have a team that is on the same page, and we're going to take the worry from them as much as we can to treat their child. So then we go ahead and schedule the baby. All right, so case number 2. So imagine you are just starting your program, right? You're psyched, right? You've done your research, you've read the literature, and you go live. Your hematology oncologists are on board, your ophthalmologist on board, and you're live and ready to go. That next Wednesday, you get your first case. And I'm saying it like this because this is my experience. And so case number 2 is going to be a 5-year-old boy. They're 18.5 kilograms. They're presenting with recurrent retinoblastoma. It's only involving one eye. They already underwent systemic chemotherapy. Remember, your institution did not have access to IAC before. So now the question is, this is your first case. What is your plan? All right, so let's go into intraoperative management protocols and setup. Now, the first thing I want to stress is have a trained team, okay? Have a trained team, have a trained team, have a trained team. My first picture indicated that children are not little adults. And so it's very important, if your team that you're using for your adult procedures only do adults, that you train them on the small details that are very important that can make a case go really well or go really bad. And there's a saying that you're only as strong as your weakest link. And so what I did when I was building my program was I took the time to train my technologists, train my nurses, and my anesthesiologists. One of the things that occurs during this procedure, and it was so funny, when I was talking to our anesthesia who was covering our very first case and warning him that has happened, is for some reason, babies lose their CO2 in tidal volume. Now, some people call this a blah, 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 oculociliary reflex, bronchospasm. There are many names in the literature for it, but it is a phenomenon that's not just associated with intraarterial chemotherapy for retinoblastoma. I've seen it happen when we had an umbilical arterial catheter treating a child with vena Galen, and as soon as we had that guide inside the internal carotid artery, the baby's end tidal volumes disappeared. They started dropping their oxygenation, and then what can actually happen is it can lead to respiratory failure, bradycardia, and cardiac arrest. And so when I was a fellow, I actually saw that for the very first time completely play out from the beginning to end. Thank God, baby did well. But it was a little guy who was about, I think I want to say he was 35 weeks premature. He had a vena Galen. He was coming for his first treatment. And we put the catheter in. We didn't even make it intracranially. We were just intracranially at the level of the ophthalmic. We didn't catheterize the ophthalmic. It was just a guide catheter. And then the anesthesiologist says, oh, something must be wrong with our machine. We lost our end tidal volumes. So then my mentor, attending, brilliant man, he pulls all of the catheters out and tells the team that this can happen when there's a catheterization. Now, anesthesia was not prepared for this, and they were not convinced that it had to do anything with the catheterization. They were convinced it was their tubing. So as they tried to figure out why their tubing wasn't connected up, the baby's pulse ox continued to drop. And then they called for backup. Baby's pulse ox continued to drop. And then by the time backup came, baby's heart rate began to drop. And that was my first time giving cardiac CPR to a little tiny baby who had just been born a few hours old and premature, due to that lack of communication, understanding, trust between my attending, who has experience in this phenomenon and was trying to tell the anesthesia team what was going on, and them thinking that no, we've never seen this before. It's something we've seen associated with malfunctioning of our equipment. And so when I had my first case, I told the anesthesiologist, hey, we don't know when it happens. Sometimes it happens the very first case. Sometimes it happens the second or third case. Sometimes it happens when the catheter is in the ICA. Sometimes it happens when the catheter is in the ophthalmic artery. But you can see the end tidal volumes go away. It can become harder to ventilate. What we'll do is we want to know that information. We're going to pull all our catheters out. We're going to let you stabilize baby, and then we'll resume when you give us the okay. So I told him, and he heard me, and he was ready. But when it happened, he came to me at the end of the procedure and it's like, I cannot believe this happened. You told me, but it happened. And so there was a moment of panic for him, but then he was able to regather things. Nothing went sideways. Baby's pulse ox never went below 90. But I say these stories to tell you, make sure your team is trained. If you have access to someone like myself, which I will give you access to me, talk over if you're thinking about doing something pediatric in mind, because there's a lot of, like I said, small tips that can be passed on that can make you have a successful outcome in practice. You're only as strong as your weakest link. All right, so now we're going to extra precautions and setup, right? I told you this talk is really, if you're doing IAC for the very first time, how can I get my program running? So baby is coming back, is intubated, your anesthesia team is all caught up. Afrin has been given generously up the nose. We'll talk about that. Phenylephrine cream has been applied to the forehead if needed. We'll talk about that. But how should baby be put? So anytime you have a kid who is less than 2-3 years old, the common femoral artery and the common femoral vein are very much close together. And so when you're getting access, you can end up puncturing through and through and creating an AV fistula. Never had that experience, but in theory, it can happen. And so the one thing you want to do, regardless of whether you're doing an IAC, diagnostic cerebral angiogram, is to have the baby in frog lateral position. So here we have an example. You're taking the heel of the baby's foot. And what I tell my techs to do is put it up to baby's butt. They're so flexible, they can do that. So frog lateral position will actually separate the common femoral artery from the common femoral vein and allow you to be able to access the common femoral artery easier. I actually do it without an ultrasound. The reason being is because I find when my eyes are up on the ultrasound screen, my throw can be misplaced and I end up with a high puncture. Fixable, right? Because you're always going to check on imaging to make sure where your puncture tip is, where your needle tip is. But I'd rather not have to repuncture because kids like to vasospasm. And so I really was taught during my training, and I really like using my fingers and getting access. I use an ultrasound if I can't get in. To each their own. Pressure bags, right? Tiny, tiny little people, 5-6 kilograms. Make sure your techs know no bubbles. I don't use air filters. We just do a really great job of making sure there's no bubbles in our systems. Air filters you can if you want. And also remember the heparin amounts. So you're putting heparin into these bags. Some people don't. I do. And I haven't had the complications associated with common femoral thrombosis, ICA thrombosis, dissection, all those things. The heparin bag should have a dose based on age. So if the baby's less than 1, you want 1,000 units per 2 liters, 1,000 units of heparin per 2 liters of saline. We use Plasmolite. That's a different story. You want for kids who are 1 and older, 2,000 units per 2 liters. And then of course, adult sized children, 4,000 like you would do for your adults. Here's another trick and tip is when you have this sheath hooked up to the common femoral artery, this yellow thing that I'm pointing to here is a flow limiter. A flow limiter allows you to control, just like you would for an IV, the rate per hour that baby gets. And so when you have these little teeny tiny less than 1-year-old babies, you really want to hook up a flow limiter to that common femoral artery. So it's just, the bag is not turned up. You're more concerned about the bags that are on your catheter. This one, take it easy so then you don't have to worry. I don't put bubble filters or flow limiters on my other lines because I like to control my flow, especially if blood is backing up. But for my common femoral artery, I always do this for all kids who are under 18. Then last is the pulse ox. And this is a great paper that was put out by the Pediatric SNIS committee. Definitely worth a read. It's just basically practice recommendations when you're performing a diagnostic cerebral angiogram. Pretty much IAC is similar to doing a diagnostic cerebral angiogram. So if you put all their recommendations to use, and that's what these pictures are coming from, it will serve you well for your getting your practice started. So here we have a pulse oximeter on the toe. I tell my techs, put them on both toes, because if I can't get access on the right, I don't want us to have to fumble under the drape to get access on the left. Again, have your team well prepared and trained and makes your life so much easier and so much smoother. And then how many people out there would place a Foley in baby and an A-line in baby for this procedure? Don't. Okay. Procedures that are going to be less than 2 hours, even 3, it's not worth the risk of an infection, and kids like to get infections from Foleys for some reason. And A-line, I usually do put an A-line in all babies when I'm doing intracranial work. And of course, the ophthalmic is considered intracranial. However, it's such a light procedure. I do not put an A-line in these babies. All right, safe technique. You're still in the intraoperative suite. Now your team has all set up. What are you doing? So here's a picture. And I like this picture because based off of this picture, we can estimate the age of this child. We can see that there's partial ossification of the femoral head, which can get a little tricky when you're getting access and you're trying to prevent retroperitoneal hemorrhage. Remember that the ossification of the femoral head happens between 4 to 6 months. So if you're starting to see it, you know this baby is not less than 3 months old. But sometimes I say that to say it's not going to be there. So what you want to do, so here again, we have an ossified femoral head, but what you want to do is look at your acetabulum and try to stay in that 2/3 lower than the acetabulum when you're getting access. And that's to prevent retroperitoneal hemorrhage, which could be catastrophic and cause death, and babies who this is not recognized in, and they start suddenly are tachycardic and hypotensive, and then you find out that they have a retroperitoneal hemorrhage. And I have heard physicians who've done this procedure state that they've had death due to that. So you don't want to be trying to save baby's life, but take baby's life because you don't have a good puncture access. And then number 2, safe technique. It's different from adults. This is a picture of a vessel with calcified clot within it due to fibers from the drapes and the towels that we put down. Now, when I was in training, I had 2 very conscious attendings who even had our techs turn the towels down a certain way where the seams and the stitching wasn't up in order to prevent fibers. Now, initially I thought, wow, neuro-IR, OCD, they go hand in hand, right? Until I read this paper that actually talks about that fibers were found in children who underwent intraarterial chemotherapy, but still ended up going on to enucleation, blocking vessels to the eye. So our number one goal is save life. Our number two goal is to save the globe. But then, of course, we would like to save vision if we can. But if we have fibers from gauze, I do not allow gauze on my table, or the drapes or the towels that we set down, like the surgical towels are the worst. So we get a special ordered green towel that can be introduced into baby and block their small vessels. So take those extra precautions. Let your team know this is actually important, and have the team that wants it to be important. And then, of course, when you're doing the procedure, these children, especially those with the RB1 mutation, have a higher risk of developing other cancers in their body. And so you want to do low dose protocols as much as possible. And again, this work does a good job of talking about lowering dose, variable frame rate, using roadmap instead of doing an angiographic run, et cetera, et cetera. Your fluoro time goal is less than 3 minutes, and your dose air karma is 3 to 4 milligray. That's your goals. Those are high goals. I'll put that out there. All right. So suggested recommendations. You're doing the procedure. I recommend use of a marathon catheter. The big institutions actually recommend Magic. Now, initially, that was what we were using. We like Magic as 1.7 French, 1.5 French. So it's very gentle, it's very soft, but it's a flow guided catheter. And so it doesn't really like to lodge in the ophthalmic artery, as well as these more stiff catheters. So the marathon catheter has been really great. It only comes in a straight tip. What you'll do is you'll go into the ICA. Like I said, I have a guide in the ICA somewhere. Go past with the microcatheter, and then just pull it back to allow it to lodge into the ophthalmic artery. Sometimes the kid can have an ophthalmic artery that comes off the side or at an interesting angle. I find the Echelon catheter does a really great job of that. Echelon 10 with a 45-degree tip. Outer diameter is actually smaller than the marathon catheter, and it actually comes in a 45 or 90-degree tip. I've never used a 90-degree tip Echelon 10 in my life, but it gives you the option to really get in there. And then an Asahi Shikai is the wire of choice that I use because it's gentle. I've never had a dissection. I don't want a dissection, because the last thing you want to do is go tell a parent, not only did I not treat the tumor, but I also gave them the risk of a stroke, and now we're admitting your baby for that. So I do like the Asahi Shikai 008, very small, gentle wire. I'm looking forward to the 1.0 wire, the 0.10 wire from Aristotle coming out. I'll give that a go. Then when you're injecting the dose of chemotherapy, remember, controversial. We're not really talking about how much. Look at the literature, talk to other institutions, talk to me. I can give you recommendations, but whatever you're doing is 1 ml per minute. So how your pharmacy constitutes the drug, you don't want to rush and do more than 1 ml of chemotherapy per minute. I live by this. I'll die by this. I preached it to my adult guys doing our cases. Case number 3. So we're moving on to post-op care now. So this is a 3-year-old girl, has undergone successful IC with great response. However, mom is concerned about a rash that has developed. And so even though this is an example of an exam under anesthesia, we can see tumor. This is what it's going to look like after a child has undergone a couple of sessions of intraarterial chemotherapy. Usually the EUA is 3 to 4 weeks after the IAC. And then you're scheduling 4 to 6 weeks, your follow-up IAC, if there's been response or no response or whatever you and your ophthalmologist are deciding. But sometimes about 2 days later, 48 to 72 hours later, children can present with this rash. And interestingly enough, even though you're saving life, saving globe, saving vision, parents are not happy about their babies not looking like they want them to look. And that's normal. Hey, that's the world of pediatric and IR. And so before we go on to some of the complications of this procedure, let's talk about postoperative management. So all of our children, when we first started our practice, we actually admitted children overnight. That was because we were a new practice. We wanted to make sure things were going in the right direction. We wanted to see if those who had been doing the procedure far longer with increased volume than us were correct in sending their kids home same day after the procedure. And we found that there was no need to keep those kids in overnight. There was nothing being done except for them occupying a bed. And so we started sending them home. Our protocol is we keep all of our children who cannot lie still on their own, which is going to be all your retinoblastoma children with retinoblastoma on a Presidex strip for 3 hours strict flat time, 4 French sheath, 3 hours strict flat time. I went down an hour. It used to be 4 hours for French, but I do 3 hour strict flat time. I make sure the puncture site is visible at all times. Again, you should feel confident that you punctured low. You can never puncture too low, but you can always puncture too high. But I don't like surprises in little babies who don't have much reserve. So I don't allow any of our nurses or people involved with care, mom and dad, to cover the puncture site. So we literally have blankets across the chest, blankets across the legs, blanket on this side, and then a little bit of a square that actually keeps the puncture site visible, because kids don't have reserve and a little bleeding goes a long way for them. And then we give their postoperative instructions, and we go ahead and put them on the schedule because we don't want their chemotherapy treatment to be delayed, because we've accidentally scheduled a lot of elective cases or have an emergency case. So we schedule them at the completion of their IAC case. But you are going to have complications sometimes. And this is a picture that I stole from the literature from this paper that's cited below. I've never had this complication because I tell you, I do not go faster than 1 ml per minute. And so some people describe a lot of periorbital erythema. You can lose eyelashes. I did have a kid do that, but they grew back. You can also get that rash. And so one of the things I recommend to avoid the periorbital swelling, 1 ml per minute. For the rash that I showed you from our case, you're actually going to put topical phenylephrine, which is Preparation H. That's what we call it in the States. You're going to just have your tech slather it on the forehead. It just means there's a trigeminal branch that goes to the scalp off the ophthalmic artery. That chemotherapy is causing those cells to die. But if you just tell your tech I just tell them to slather the whole forehead in phenylephrine, you won't get, it looks like this little baby has that rash a little bit here, you won't get that rash. Another interesting complication that we published just recently, this will hit in October. Wait, it already hit. Great. It's already hit, where one kid, we put a generous amount of Afrin, not 2 drops, but a generous amount of Afrin into each nostril to cause vasoconstriction of the nasal branches of the ophthalmic artery to keep flow going towards the central retinal artery, the arteries that provide flow to the globe, and instead of going to the nose. So we put generous Afrin up the nose. We did have a young boy who developed urinary bladder retention from this process that worsened with each IAC procedure that we had to give Flomax to in order to get him to be able to pee after the case. All right, case number 4, and I'm probably running out of time, so I'll try to speed it up. What happens when you're in the operating room, endovascular suite, and the ophthalmic artery is missing? We go back to that case. So I'm going to show you here. We can actually see where our catheter ended up, and I'll play that again. You can see the tip of the catheter is here. You can see that there's choroidal blush here. So this is the classic sphenopalatine, less common collateral branch that is given that choroidal blush to the orbit, that you want to get your microcatheter out as far as you possibly can and then deliver the chemotherapy. So the most common variant that is taught is the middle meningeal artery. I did not feel the need to show us that collateral because a lot of us are doing MMA embos for subdural hematoma treatment. So we're very much familiar with anatomy, but this one is a bit rare, where it's coming off the distal internal maxillary artery, and it is one of the sphenopalatine artery branches. And so be aware of that. Now, a few things about this. When you are in the ECA, you're less concerned about rigidity of your catheter because the ECA is a bit more robust. And so Echelon 10 is my catheter of choice with a 45-degree tip. It allows me to use an Aristotle or 1/4 wire to get out where I need to go. Now, the goal is, what do you do when you're faced with these anatomic variations? Well, you get out as far as you can. And when you do your microcatheter injection, you're just looking for the blush that lets you know the chemotherapeutic agent is going to get there. And what I have found, but I haven't done a study yet, is that when we're treating from the ophthalmic artery, there seems to be more dilution along the way, that we don't get as good as a response as when we're treating from ECA branches. So some people consider, if a patient has dual supply, treating through the ECA, because it seems that the less distance, the less dilution you get, and the more power you get from the chemotherapeutic agent hitting that eye. So just a few thoughts about that. Last thought. A lot of people say that that oculociliary reflex or bronchospasm reflex is secondary to catheterization of the ophthalmic artery. Well, this baby, on his very first case where he had the missing ophthalmic artery, this is retrograde filling, just a reminder. When I went out here and got my catheter there, he actually developed that bronchospasm. And so the question is, what is the cause of it? Doesn't matter whether you're in the ICA or the ECA. And so we're working with our anesthesiologist to write that case up. All right, last case. Now we're getting into controversy. This is a 2.8-month-old girl who's presenting with bilateral retinoblastoma. She's in the 80% percentile, and I'm going to show you the MRI. So you can see on the left eye, there is extensive tumor in this eye. Extensive. And this was the same baby that actually had some tumor extending outside of the eye. The question I want to ask you is, would you offer this baby IAC? So is IAC beneficial for babies who have a group EI? Group EI means significant tumor throughout the orbit with extension outside of the orbit. But also group E can be just a lot of tumor, no extension, but just a lot of tumor. And so there's some controversy of whether we should be using intra-arterial chemotherapy for group E patients, when the thought process is the chance for metastasis is higher. And so I love to announce that the first randomized controlled trial in this space of IAC was published July 31st, this past summer of this year in China. And what they did was a wonderful study, I thought, looking at their patient demographics, looking at their protocol. There were 6 tertiary pediatric centers. The treatment of choice was randomized by center. So either you're getting IAC if you go to this center, or you're getting IV chemotherapy, systemic IV chemotherapy if you go to that center. They had it where the patients only could have unilateral disease, so one eye involved. Group D and Group E, no prior exposure to systemic chemotherapy or any types of treatment, including laser, which usually is reserved for Group A, B eyes. And so, intra-arterial chemotherapy is touted as the treatment of choice for grade D eyes. But E, there's a lot of hemming and hawing when it comes to E, because some people are saying, no. We cannot do IAC because METs are going to happen. METs are likely to happen. METs are already happening. We should just go to systemic IVC. But what they found was that IAC improves globe salvage with mild systemic complications. So remember our mantra of preserve life, globe, vision, right? So they didn't comment too much on vision. That's okay. But IAC improves globe salvage in comparison to systemic chemotherapy, milder systemic complications in comparison to systemic chemotherapy, but no difference in the overall survival rate or metastatic rate. And so a lot of people would argue, and some people are, the NYU group definitely is, that IAC should be the standard of care for patients with group D and E eyes that are unilateral based off this study. And again, it was a great study. There was 176 patients, which is not a small number. We have treated a total of 30 children, can't remember number of eyes, since 2000, 2018 with the initiation of our program, because retinoblastoma happens 200 to 300 children in the USA per year. So 176 patients is a good number. 72 of them had intraarterial chemotherapy. 71 of them had intravenous chemotherapy. The split between D and E eyes was about 50-50. And so the question remains, if a patient presents with group D eye, I would say unilateral, go for it. If a patient presents with a group EI without high-risk clinical features, which is extension out of the tumor, extension out of the globe, extension into the ophthalmic, into the optic nerve, that is controversial. That is a go, possibly, but there's still controversy behind it. So we need more studies, more evidence to decide what we're going to do. Now, there's another thought where some of our ophthalmologists and his ophthalmology friends think that children, even with group E eyes, because of the mechanism of action of intraarterial chemotherapy, should at least undergo 1 or 2 treatments, even while they're getting systemic chemotherapy. And their thought process is that if there's any tumors that have escaped outside the globe, that direct distribution of chemotherapy to the eye, that localized effect that IAC provides, is worth it and improves patients' risk of metastatic disease, or lowers the risk of metastatic disease. So you have all these talks, and we're working on our experience paper right now to make some conclusions on our own. And truly, we feel like all of these papers should be contributed because we just don't have a lot of randomized controlled trials, but hopefully that's something that we see in the future. So in conclusion, if you don't remember anything I said today, please remember these 3 points. 1, it takes a village. If you are starting your own program, call your friends, call me, I'm available. I want to do some outreach work. Call your hematology, oncology, pediatric experts, your pediatric ophthalmology experts who are well-versed in this disease. Put your heads together and be a village to take care of that child. Number 2, have a plan and a protocol. That comes from combing through the literature, your own personal experience, the experience of others. So again, reach out to people, get connected with people who are doing it to kind of see what the differences are and where you want to go. And then lastly, we definitely research in a registry for this disease. It's like one of the few pediatric cancers, our ophthalmologist was saying, and hematologists, oncologists are saying, that has not had these randomized prospective studies because of low numbers and other limitations. And so definitely more research and registries and surveys should be performed. And that's all I have to say. I'll leave the floor open for questions. Thank you so much for listening to my talk. Thank you so much for inviting me. Hope you guys enjoyed the talk.
Thank you very much, Dr. Misha, for giving us this wonderful talk. We have eminent ophthalmologists with us, including the Dean of Faculty of Clinical Sciences in Luz, Professor Akinshola, and also some other ophthalmologists. Professor Aribaba, Professor Honokoya came in at some point. At the peak, we had close to 60 participants cutting across neurosurgeons, ophthalmologists, and other surgeons with interest in the topic. Thank you very much indeed. We would like to take questions. Please, you can type your questions on the question box. You can also raise hands to ask your question directly. Meanwhile, there are some questions that have been written. If you want to read through Dr. Misha, and then you can answer the questions.
Thank you, Dr. Joe. Thank you, Dr. Martinez. You've been fantastic with your presentation.
Thank you.
Couple of questions. I think there's one already in the chat box. It says, can you give us your reflection on the best ways to catheterize the ophthalmic artery?
Yeah.
I mean, I remember in fellowship, sometimes we spend an hour trying to get in there. It's a
Oh,
pretty
yeah,
tricky
yeah.
sometimes.
And so that's why I thank you, Karen. Shout out to my bestie Karen in Texas Children's. I invited her to this talk. But no, and thank you for all those who said thank you to me. And yes, I will provide my email. I was perusing the chat myself. So that is the thing. So again, do not use magic. Okay. Don't use it. Don't do it. Just stop. Okay. I know it's soft. I know it's flow guided. I know people like to show those pictures of just like dropping it into the ICA. And the reason why is, one, it doesn't have enough support to stay in the ophthalmic artery. Two, it's a flow guided catheter. So even if you get a 3 French access in the common femoral artery and you go up with a magic, you're going to increase radiation time. So I've tried them all different ways, seen different ways. I do a lot of peds neuro IR, so I don't recommend using a magic, and I don't recommend not using a guide. Number 2, have a guide up in the ICA. Sometimes what happens is that I have noted myself, if I have my ICA low, if I have my guide low in the ICA because there's a 360 hairpin loop in the ICA that I don't want to cross because I don't want a dissection. If I inject very forcefully, mind you, in this 1-year-old, 2-year-old little person, I don't opacify the ophthalmic artery. And so sometimes I think that a lot of these cases where they're being done through the ECA, it's because they're not opacifying the ophthalmic artery with their injection because they don't have a guide. All right, I have to add that. So what am I doing? My guide is giving me good support, and then I'm going up with a microcatheter. I'm going past the ophthalmic, and then I'm just slowly pulling it back. Just like a pipeline wants to jump on you when you're pulling it back, this catheter wants to do that and skip the ophthalmic. The key is you're going millimeter by millimeter. It's almost, again, like watching paint dry when you're injecting the chemotherapy, but everything you're doing in children, you're doing it slow, you're doing it gently, and you're doing it with time, slow. So you literally just want to pull it back. Now that's what the Marathon straight catheter, again, the advantages of a Marathon, it's a little bit less stiff. Outer diameter is 2.7. It's gentle. Okay. Now Echelon, the outer diameter is actually smaller than the Marathon. The inner diameter is actually larger. So you actually get to put an 014 wire instead of a 010. But the cool thing I think about Echelon is that Marathon doesn't just flop in for you, is that you can get a 45-degree Echelon. It's a little bit more stiff and rigid. And what it will do, you can actually not just have it flop in, but it actually clicks in and engages. And so that's what I would actually recommend. You change that Echelon from that Marathon. And then the last thing being something you don't want to do unless you have to, but it's doable. Use that Echelon with an Aristotle wire, which, like I said, that wire goes anywhere. Just get that wire inside the ophthalmic artery and then track your ophthalmic catheter over it. Then you're going to get inside the ophthalmic artery and you're going to sweat a little bit because it's like a 1-year-old or 5-week-old or 3-month-old ophthalmic artery. It's okay. Very gentle. Don't spasm. You're going to pull that microcatheter out again, very, very, very slowly to the ostium. You do not want to treat inside the ophthalmic artery because you're going to shut that ophthalmic artery down. Now, I've never had an ophthalmic artery shut down for me. And I know this because I have a guide that I'm actually doing my injections with to find it. Can get a little bit narrowed, a little bit stenotic, but my guide, I can do a good angiographic run and see. But that's because I'm always at the ostium of that ophthalmic artery. So those are my tricks and tips. I've never had to go through the posterior circulation, through the vert, through a PCOM to drop into ophthalmic by using a Marathon, an Echelon, and then an Aristotle wire. The Sahi Shikai wire, actually, if you put the very tiny, not even 45-degree, little less than 45-degree tip in it, it will engage the ophthalmic artery too. And then again, you have to get that ophthalmic artery out into the ophthalmic. Get that wire out into the ophthalmic artery, track your catheter along, leave the wire out as you're pulling your microcatheter back. So just in case if you pull it out, you don't lose your access. Then retract it again and then make sure you just land it in the ostium. I hope that makes sense.
Thank you very much. It's been very helpful, I'm sure, to everyone. Just wondering, Dr. Joe, do we have any of the ophthalmologists that would like to make some comments from Luth or in the audience? Please feel free to just raise your hands or unmute and make your comments, please. Would love to hear from you.
Yes, please teach me. I'm still learning from my ophthalmologist
Pediatricians, ophthalmologists, anybody on the line?
and hematologist all the time.
Yes, please. We would like any of them to make comments if they have. I can see the professors are still there in case they have.
Hello, Dr. Martinez. My name is
yes,
Akin Shola. It's very early here, but I've enjoyed your talk thoroughly, and kudos to all the work you're doing. For us, we are still yet to start this method of treatment for retinoblastoma, but I believe when we up and doing, the neurosurgeons will be with us, and as you've said, others too will be involved, the anesthesiologist and pediatrician. Everybody will have to have their hands on the deck. Thank you very much. I appreciate it. Bye now.
You are so welcome. Thank you so much for joining us this early. I wish you all the success in your program, and I wrote this talk for you guys who are starting your new program.
Dr. Martinez, you said you'd be happy to do outreach while you were giving your talk towards the end. It's an aspect we would like to take you up on when the time comes.
Love
I
it.
would very much like to get involved.
Absolutely.
Professor Nokoya is willing to make a comment. Professor Nokoya, please go ahead.
Good afternoon. Thank you very much, Dr. Martinez. Just to say that one of my colleagues, who is a pediatric ophthalmologist, and she's quite vast in retinoblastoma treatment, she's online and she's writing her comment because she's actually done some NI neurointerventional chemotherapy for some patients, which they did in January. Dupe, can you talk? She's typing. I think she's on a journey. So
please.
Thank you so much, ma. Good afternoon, everyone.
Okay, yeah.
Dr. Martinez, thank you. Can you hear me?
Yes, yes, go ahead.
Sorry, I happen to be in transit, so my network could be challenged. I just want to say thank you. We started IAC intraarterial chemotherapy in the country in January. We did 3 eyes of 2 babies. And we had another child in August. Our main challenge is funding. We have patients every day who need to have IAC, but you know, treatment in Nigeria is out of pocket. But at least we're happy that we're able to even start this and give back. And on the average, one should be preparing for like 3 courses, but we've not been able to do more than 1. In any of our patients, we've had to follow up with focal treatment. I'm sure you don't get to have that kind of a challenge in the US. So but just to say thank you, we're trying to move with the world. Thank you.
You're absolutely correct. You know, when you're reading the literature, it states that the cost for IAC versus IV chemotherapy right now has dropped to the point where it's comparable or cheaper. And I think that's because a lot of these large centers have done lots and lots of eyes and they've been concentrated there. And so a lot of the, as you said, the cost implications, we don't talk about as much. But I believe that if we look to see what general practices are and increase standardization of these practices, then we could help other countries create centers that are the go-to centers that will decrease costs, increase outcomes because the volumes will be so high. And then we can offer this, which is needed in India and Africa, as I stated at the beginning of my talk. And so that's why this is one of my goals. As a peds neurointerventionalist, my dream is to help others tap into my expertise to help people all over the world. And so part of the things that I'm thinking of is writing grants to help kind of get things started in other countries and implementing programs and volunteering. And I know other people that would love to come over and help get things implemented, donate catheters and devices. I know one of our guys does that for his country back in Belize. He'll take all the stuff on Uber to provide them for the pediatric interventional radiologist. These are some of the efforts that I hope to do in my near future to help those who are trying to get started go ahead and get off their, get running on their feet. So thank you for your comments. Thanks for joining us. And yes, these concerns are true concerns.
Thank you very much. I think our time is up.
It is. It is up. I did see one thing in the chat where it said, what are you doing for children less than 3? You're bridging with systemic chemotherapy. But just in case you missed that part, I just wanted to make sure you're bridging with systemic chemotherapy, and then you're waiting till they're 3 months to go ahead and get them started.
Okay, thank you very much. We are actually trying to team up with, we're in the process of teaming up with the Lagos University Teaching Hospital to start off a program in the hospital there.
Nice.
But the program, there's a Dr. Nilowo who started off a program, actually delivering chemo, IAC. So that's been wonderful. And we're hoping that we can get the funding we need to help these children back in Nigeria and all of West Africa.
Yeah.
So we're working hard at that.
Yeah, and I feel like the grants are there. As I was talking to our colleagues here, when it comes to children and it comes to cancer, there is money. And so you reach out to those who are like, I'm very close friends with our PhD who's interested in retinoblastoma work, because he's like, if you write a grant, you'll get the money, because we're all about improving outcomes for our children. And so I think it's just focused efforts, being intentional, and you can make it happen.
Thank you very much, Dr. Martinez. We really appreciate the wonderful talk you've given to us today. Dr. Joe, do you want to close us out today?
Oh, once again, Dr. Martinez, we are very glad you were able to give this talk, and we appreciate immensely the knowledge that you've passed across, and also making yourself available for future collaboration. Dr. Kafo, thank you very much. And everybody that have attended and given opinion, the comment, we appreciate you. The next Grand Run would hold on Wednesday, 13th of December, 2023. And we'll be talking about endovascular treatment of subdural hematoma. The presenter will be Professor Andrew Grandi, Associate Professor at University of Minnesota, and Dr. Chizoba Ezepoe will be the moderator. Please keep the date. We will send reminders as the day gets closer. Thank you very much, everybody.
Thank you, everyone. We'll try and send out the recording. Please put your email on the chat box before you leave.
I sure did.
Recording across to you.
Excellent.
What are your slides? Can we get the slides?
Yeah,
okay,
absolutely. Yeah.
We'll pass that on as well. Thank you, everyone. And we'll see you in December. Thank you.